I'm Brian Rini. I'm a GU medical oncologist, professor of medicine and chief of clinical trials at Vanderbilt University Medical Center. Debulking nephrectomy in kidney cancer is a concept that's been around for a very long time. And it has sort of a long history. So the concept is a patient walks in with primary tumor in place and distant disease. So you're doing a nephrectomy, you're removing the primary tumor, i.e. debulking the disease, but not surgically removing all the disease. There were retrospective series decades ago that suggested those patients did better. There were trials in the 1980s that looked at debulking nephrectomy or not compared to, and then interferon for all patients. So surgery plus interferon versus interferon that showed a survival advantage in the debulking nephrectomy group, 2 separate studies, one in the US, one in Europe. And so that was really the standard of care. But I think, even during that time, before some more recent data, patient selection was always very critical. So good performance status patients, the bulk of their total tumor burden in the kidney, resectable disease, et cetera, good performance status. So that was always the criteria, and patient selection was always imperative. Then those studies were repeated now with sunitinib as the standard therapy. So basically sunitinib plus minus nephrectomy, a trial called Carmina reported a year or so ago. That was a non-inferiority trial that did show them to be non-inferior and somewhat put into question the role of nephrectomy. But again, I think the interpretation of that data is a bit complex and a bit varied among specialists. I still think debulking nephrectomy has a role in very appropriately selected kidney cancer patients. And I think what Carmina reinforced is that when you don't select patients well, as they have more adverse risk features, as they have more disease outside the kidney, that those patients probably aren't going to benefit and certainly should start systemic therapy. So I think the pendulum swung back a bit towards systemic therapy first, but not entirely. And then lastly, I'll just say that there are even more studies ongoing now with our modern therapy. So just when the surgery question catches up, then we get better systemic therapy and people ask the same question appropriately. So there's a study that I think is called the PROBE study that is looking at basically same question, plus minus nephrectomy and modern systemic therapy, some sort of immune-based regimen. So I think it'll always be around, and I think patient selection will always be important, and the practice of actually doing it, I think, varies by country and by physician.